Dr. Sushma, are you with us?
Good evening, sir. Yes, I am.
Are you comfortable? Can you try quickly sharing for a trial? Please switch on your video.
Can you hear me?
Yeah, very well.
Yes,
Just settle down comfortably. Don't come close to the camera. Sit down properly. Yes, adjust the camera so that it is in neutral mode. Yes. Try sharing your PowerPoint, Dr. Sushma.
Should I start?
No. You please share. Vishrut will be
Yes,
presenting first.
Yes, sir.
I just wanted to check things are okay. Have any challenges in doing that? Warm welcome to all of you friends, 8 o'clock. And we warmly welcome all of you for joining this evening. We first warmly welcome the senior faculty who have joined us. Professor Palam Praveen sir, Professor Madhumita ma'am, and Professor Rajendra Desai sir and Rajiv Sakai sir. The others are expected to join anytime soon. So today the sessions will be coordinated by Dr. Rajiv Sakai sir. After I start the session, by Professor Nishikant Gujar sir from Alamin Medical College, Vijaypura, Dr. Vishrut. He is going to present a case of cancer breast. And the second candidate is kindly contributed by Professor B. Shanti ma'am, Director in charge of the Institute of General Surgery at Madras Medical College. So Dr. Sushma Selvanathan will be presenting a case on Parotid. It's the second case. So friends, good luck to you. Rajiv Sahai sir, you can take over. And I request Dr. Vishrut to introduce himself, your head of the unit, head of the department, and start your presentation. Yes. Faculty, kindly take over. Invited faculty take the preference. So please take over and conduct the proceedings. Over to you, sir. Please.
Good evening to all the professors. I'm Dr. Vishrut, junior resident from surgery department. I'm presenting this case under the guidance of Dr. Nishikant Gujjar, professor and unit head of my unit. And I would also like to mention my HOD's name, Dr. Sajid Mudol, Alamin Medical College, Vijaypura.
Dr. Vishrut, you have to make your screen share, like screenplay, full screen. Yeah, good luck to you. All the best. Yes.
Thank you, sir. Can I start my presentation, sir?
Yeah, please do. Please do.
A 45-year-old female housemaker comes to the hospital with a complaint of lump in the right breast since 6 months. History of presenting illness: patient was apparently normal 6 months back when she noticed a lump in the right breast insidiously while taking bath. Initially was approximately a size of 2 × 2 centimeter. It has gradually increased in the size since then to attain the present size of 3 × 3 centimeter. No history of pain, no history of fever, pus, or redness over the breast, no history of discharge from the nipple, no history of any nipple retraction. There's no history of ulcer over the breast, no history of recent weight loss, no loss of appetite, no history of swelling in the axilla or the neck, no history of chest pain, breathlessness, cough, hemoptysis. No history of pain in the shoulder or back or abdominal distension. No history of jaundice. no history of trauma, no history of swelling in the opposite breast. Past history, patient is not a known case of diabetes mellitus or hypertension, no history of taking oral contraceptive pills or hormonal replacement therapy, no previous surgeries in the breast, no history of similar complaints in the past. Family history, no history of breast malignancies in mother or sister. Menstrual history, age of menarche is 13 years. Regular cycles, age at first childbirth was 20 years. She is a P3L3, all are normal vaginal delivery, no abortions. Breastfed all 3 children up to the age of 1.5 years.
Okay, Dr. Vishwat. Right. The invited faculty can please take over. You can ask the questions on the history.
Let him complete till the general options.
No, so what we do usually is that we quest them on the history,
Okay.
and then take the examinations. If anyone wants, otherwise I will ask the questions.
Okay, Vikrut,
Yes, ma'am.
why do you take a history of trauma?
Trauma, just to rule out traumatic fat necrosis, which mimics as which has similar complaints, ma'am, like heart swelling in the breast. Just to rule out CF.
Dr. Vishwat,
What do you mean by
Dr. Vishwat,
Yes, sir.
what is characteristic of traumatic fat necrosis of breast?
Sir, it is usually the history will be very long, sir.
So just one injury can cause traumatic fat necrosis?
Um,
Just a single episode?
no, sir.
Then, okay. Tell me, what is the characteristic of, what are the few things which characterize that this is traumatic fat necrosis?
Sir, patient gives history of any trauma, which later has.
No, they don't. Usually they don't.
Okay, sir. Patient will suddenly notice patient might notice a swelling, which is hard and consistent.
What is the age of patients who present with traumatic fat necrosis?
Sir, at the age of 60s or 50s or 60s.
Elderly patients
Age.
with floppy breast. What happens is that they sleep on their arms, and the elbow, the
Yes.
bone,
Ah.
it presses onto the floppy breast
Okay.
for a long period of time,
Okay, sir.
and that causes, right?
Yes, sir.
So not a single episode.
Okay, sir.
I just would like to tell you something.
Yes,
You've
sir.
taken no history of pain, fever, nipple retraction. Just go to the next slide. Look,
Yes.
you have mixed up all the questions. Either inflammation, then you go to metastasis, then you go to malignancy, then you go to inflammation back again. It's not like that.
Okay, sir.
The history, there has to be flow.
Yes,
You
sir.
have to ask questions first to rule out what you suspect most.
Yes.
Right? You can't give me a list of, just say no history of suggestive of metastasis to such and such places. You can't say jaundice, then breathlessness, and then bone pain. That's not right.
Okay, sir.
Sorry.
What do you expect the discharge in your patient? What discharge you expect from nipple?
Sir, it's a 45-year-old female coming with recent 6 months history of this thing swelling.
Okay.
I would expect bloody discharge, sir. Or
What is the pathognomonic feature of a malignant swelling discharge
So,
about the discharge?
at the
Is
history
it bloody discharge or anything else?
sir, it's a altered bloody discharge, sir.
No. It is recent onset of serosanguinous discharge, not bloody discharge. Bloody discharge comes in so many conditions. Okay.
Yes, sir.
What about the nipple retraction? What is the reason for nipple retraction? Why you ask
The
that?
nipple retraction is due to the involvement of lactiferous ducts, sir. Cancer cells invading the lactiferous ducts, causing the retraction of the nipple.
Is it lactiferous ducts or anything else?
Sir, dimpling and puckering is due to Cooper's ligament, sir.
Yeah, very good.
Nipple retraction is due to the lactiferous duct. Anything missing in your history of present HOPA in your presentation?
Anything missing in your presentation? Anything missing in your history of presentation?
Sir,
Anything missing in your history of presentation? Anything missing in your history of presentation? Anything missing in your history of presentation?
Sir,
Anything missed in your history of present illness in your case? You have to ask about the history of radiation also. What is the reason for asking the history of radiation in your case?
History of radiation exposure to the chest wall at the age of 10 to 30 years has an increased risk of developing.
What type of radiation do you expect in the childhood? What is Montel's field of radiation?
I'll read, sir.
What do you mean by Montel's field? So you give for lymphomas, you know?
Lymphoma. Okay, sir.
Yeah. History of radiation to the head, neck, and chest wall.
Yes, sir.
Neck and chest wall. That is Montel's field of radiation. Oh, what is the latency period of radiation to given a malignancy? What is the latency period?
Sir, a decade, 1 decade, sir.
No, it is 15 to 20 years. Is there a chance of in your patient is 45 years, no?
Yes, sir. 45 years.
It shoots that radiation exposure. Okay.
Okay, sir.
What is the asked told you about the personal history, no?
Sir, yes, a personal history.
You are not told?
No, sir. I've included that in the past history, sir. About oral contraceptive pills, hormonal replacement therapy.
That is should be separate thing, no? Personal history. That's most important in your case.
Okay. Personal history, we would ask about the diet.
Yeah. Personal and menstrual history is most important.
Menstrual history I mentioned. Personal history, we will ask about the diet and also.
Which one?
Diet.
Dietary habits. Very good. Very good.
Dr. Vishruth, could you just go to your first slide, please? So she's a 45-year-old lady with a lump breast of 2 centimeters and 6 months gone to 3 centimeters.
Yes, sir.
What do you think by your history is your differential?
At the level of history, I would think of CA breast and fibroid.
Why CA breast? Why you think of CA breast?
Sir, history is only of 6 months, sir.
Yeah, so?
I would keep it as one of my differential diagnoses, sir, at this level, at the history level.
Okay. What is the other differential you said?
As a fibroadenosis and or
fibroadenosis. Fibroadenosis. What is fibroadenosis? Is it common at this age?
No, sir. It is common in the early age group.
In this age, 45 to 50 years, what is the most common cause of lump, or 35 to 45?
Fibroadenoma. Fibroadenoma.
Okay. And suppose I say this is a cystosarcoma phylloids.
But the size.
Fibroadenoma is seen in a younger patient. Okay.
Yes, sir.
At this age, it is cystosarcoma phylloids.
Okay, sir.
Right.
Yes, sir.
So why can't it be cystosarcoma phylloids?
Sir, first the size, it is very small.
Earlier stage, it's just increasing. She's noticed 6 months. It can. Yes, okay. So right. You must correct your history. History of pain, fever, discharge from nipple retraction. Now suddenly get nipple retraction. Next slide. Yes, you must compartmentalize this to trauma, congenital trauma, inflammatory, benign, and then malignant. Okay. Yes, your history should be that way.
Yes, sir.
Next slide. Next slide. Past history. Okay. No history of similar complaints in the past means?
Sir, we just wanted to know that if she had any similar swellings in the past.
Yeah, so you write that. What do you mean by just similar complaints? What complaints are you looking for? You listed 1,000, you listed 500 complaints there. No history, no nothing. So just be upfront and say no history of any lump or persistent lump previously. Okay, next slide.
Yes, sir. Please one. You should not mention diabetes mellitus and hypertension in past history.
Exactly.
It's the ongoing process, no?
Right.
Yeah.
I was coming to that.
Yeah.
Diabetes and hypertension. There's a term called medical history.
Medical history.
And that's where you put it. Right?
Yes.
So this past history business is out.
Okay, sir.
Right? Okay. Next slide. Now, no history of breast pregnancy in mother or sister.
Yes.
Do you have how many brothers and sisters does she have?
Sir, she has two sisters, sir. Two sisters.
So, right. Just two sisters.
Yes, sir.
And is the mother alive?
No, sir. Mother is not alive. Sir. Mother,
How did she die?
sir. It was cardiac problem, sir.
Okay. All this, right. Now, what are the malignancies are you looking for in the family?
Sir, in malignancies, it is invasive carcinoma, sir. Most common, or DCAS.
No. So which are the family?
What's the difference between a
Please.
familial and a hereditary thing?
Familial,
What is
familial will might or might not have genetic component, whereas the socioeconomic factors or the environmental factors play a role in the family history. Whereas in genetic, it is gene mutation. BRCA1, BRCA2, P53, leaf Romani, all this.
What's the first degree relative?
First degree relative is either mother or sisters, mother, sister, or daughter.
Mother, sister, daughter. So have you taken a proper, complete history of the family in the family?
Yes, ma'am.
One
Okay.
question, please.
So you
One
tell me
question.
what are the malignancies you look for in the family? What are the BRCA1 related tumors? What are the BRCA2 related tumors?
Sir, BRCA1 tumors are usually triple negative breast cancer tumors, sir. It is all ductal type of cancers.
I'm
Please,
not asking about breast. I'm
please
talking
listen
of
to.
which are the other tumors
Other
associated
tumors, sir,
with BRCA.
ovarian tumors, colonic tumors, and prostatic tumors.
So did you take the history for that?
Yes, sir.
So you should mention it.
Okay, sir.
That you just mentioned malignancy in mother sister. What about the brother?
Second
What about the
generation.
father?
Second degree.
What about the father? What about the brother? What about her daughters? What about her son? Okay.
Yes, sir.
So that is what I'm to say. This is inadequate.
Okay, sir.
Okay.
Is there any
next?
excellent. Is there any difference between hereditary cancer and familial cancer and sporadic cancer?
So sporadic cancers are usually seen in the older age group, sir. And
No,
hereditary
it should not be like that.
Okay.
As per inheritance, you have to tell like that. As per inheritance, based on the genes.
Based on the genes, sir, if there is any genetic modification that is leading to breast cancer is seen in the first degree relatives, and it is usually seen in sister, mother, or the daughters.
No.
Familial history, it can be
No, that is not. In a hereditary cancer, both genes are inherited from the parents.
50% is there, sir.
Yeah.
From the paternal and 50% from the maternal.
In sporadic, one is somatic mutation. In familial, one is sporadic. In sporadic, both are somatic.
Okay, sir.
Okay, that is the difference between hereditary, familial, and sporadic cancer.
Yes, sir.
Go ahead. Go ahead.
Okay, Dr. Vishruth,
Yes,
what
sir.
is this difference between BRCA1 and BRCA2? If you've got to list 4 differences.
Sir, BRCA1 is chromosome number 17q. BRCA2 is chromosome number 13. BRCA1 is usually aggressive tumors. BRCA2 is less aggressive. BRCA1 is usually intraductal carcinomas. BRCA1 and BRCA2 both are intraductal carcinomas. BRCA1 is usually triple negative breast cancers. Receptors are negative. In BRCA2, it is hormonal receptors positive, and their good prognosis is seen in BRCA2.
What about in men? If they get, do they have BRCA1 or BRCA2?
BRCA1.
No.
BRCA2.
BRCA2.
Okay, next slide, please. Okay, sorry, just go back.
Yes.
Go back. Yeah.
If you think there's a malignancy related patient, you must take her social history also, so that you know whether the patient understands her problem, whether she can afford to undergo treatment.
Yes, sir.
Right? Will the family support her?
Yes, sir.
All this is important, right?
Yes, sir.
And of course, put in a slide for your differential.
Yes, sir.
Vishruth.
Right.
Yes, sir.
What are the risk factors in your patient?
Sir, There are in my patient, sir.
Yeah, in your patient.
Age is a risk factor, sir.
As per your slides, tell me the salient features of risk factor. Is there any risk factor in your patient? What are the risk factors you accept?
Sir, age is a risk factor.
Only one is risk factor. Others are all negative.
Others are all negative, sir.
Yeah, go to the next that menstrual history and everything. Yeah, no, menstrual history. Menstrual history.
Yes, sir.
Yeah, this one. Age at first birth. Which is the risk factor in this case? Age at first childbirth.
Sir, anything less more than 35 years at the age of first childbirth is high risk factor. Less than 18 is a protective factor.
Less than 22 years, not 18.
Yes.
Okay. Okay. She is having is it early menarche or late menarche or normal?
Normal, sir.
Why early menarche is risk factor in breast cancer?
Sir, it increases the number of menstrual cycles, sir. Exposure to the estrogen and progesterone variation.
Should say unopposed action of estrogen
Unopposed
by
action.
progesterone. That sentence should
Yes,
come from your mouth. Okay.
Okay, sir.
What is Gale hypothesis?
Sir, Gale.
What hypothesis you know to assess the risk of getting malignancy as based on the risk factors?
Sir, there is a Gale mod. You're asking about the Gale model.
Yeah, Gale. What are the other theories you know? And tell about the Gale.
Sir, Gale model uses age, sir. Age at menarche,
Okay.
age at first live birth, and number of first degree relatives, sir. This is there in Gale model, sir. Other
No.
models is clause model.
No. You have 3 ages, age, 2
age,
biopsies, 1 family history, and obesity. You tell all 3. I only gave a hint. You complete 3 ages, 2 biopsies, 1 family history, 1 is BMI.
Sir, one is age at menarche, sir.
Okay. Age at menarche.
Age at menarche, and age at first childbirth, sir.
Okay.
Then number of breast biopsies is 1, sir.
Very good.
And number of first degree relatives having.
I already told, no?
Yes, sir.
1 more biopsy you have to tell.
Sir, any atypical
Yeah,
hyperplasia.
benign atypical hyperplasias, DCISS. Okay.
Yes.
What are the other hypotheses you know which is reliable and easy? What are the hypotheses you know? The hypothesis.
Sir, other.
Sir, can I ask these all questions in detail or can I skip, sir? Sai,
No, sorry, please. So,
time is
can.
limited. Time is limited.
No. Please, it's all yours.
Breast is very vast. That's why I'm asking.
The other models would be clause models, sir.
Class. Before that,
Model
thyroid cruiser. Thyroid cruiser.
Okay, sir.
What are the other models?
Bernard Fisher model.
Very good.
That's all, sir. I know only that.
Okay. What is the difference between class model and Gale model?
Sir,
Thyroid cruiser and Gale. What he has not taken into consideration, what he has taken into the consideration.
Sir, clause model is mainly with respect to the first degree relatives and their onset of the breast cancers in them. With the family history is more given.
Yeah, he has not taken the family history into the consideration. Only
Yes.
has taken only first degree.
Yes, sir.
And he has not taken the genetic mutations and also radiation history.
Yes,
He has
sir.
not taken. It was this therapeutic included all those 3.
Okay.
Okay. What? Go ahead.
Okay, should we move to
High
the
risk
examination?
lesion?
Ma'am, atypical hyperplasia, floral hyperplasia, atypical ductal hyperplasia, floral hyperplasia, all these are.
What are the relative risk for all these lesions?
Related.
Vishnu, what
Sir.
ma'am wants to ask is that which of the risk factor has the highest risk for malignancy?
Sir, age is the highest.
No,
No.
we just discussed this. BRCA,
Genetic mutations. BRCA1 and BRCA2. BRCA1 has around.
ma'am just told you something else. Atypical hyperplasia,
ductal
and
hyperplasia.
third is radiation.
Right.
Radiation.
Right? These are the only three which have greater than 4 times the risk.
Okay, sir.
Okay. Right. Should we go to the examination, ma'am? Sir?
Okay, sir.
Okay.
I'll go to the examination part, sir.
Yeah, please.
General physical examination. Patient is conscious, cooperative, oriented to time, place, and person. Afebrile, moderately built and nourished. There's no pallor, icterus, cyanosis, clubbing, pedal edema, or generalized lymphadenopathy. ECOG score is 0. Examination of the breast. After getting consent from the patient was adequately exposed in a well-lit room with the presence of a female attendant. Patient was examined. Patient in sitting position, arms by the side. Both the breast appears equal in size. Both nipple appears at the same level, sir. Mild fullness was noted in the upper outer quadrant of the right breast. So this is a photo. Skin over the breast. Dilated veins are present over the right breast, sir. There is no ulcer, no redness, no dimpling or puckering, no scars. Nipple areolar complex. Nipples are normal in shape, not deviated. There is no discharge on inspection. Areola normal in size, no discoloration, no visible mass. Arms raised above the head. There is no obvious lump. Inframammary fold is normal. Right axilla, no fullness noted. Supraclavicular fossa, no fullness or swelling noted. Inspection on leaning forward. Both breasts fall forward equally, not fixed to the chest wall. Palpation. Left breast is normal. Right side, no local raise of temperature, no non-tender. Right breast, a single lump of size 3 × 3 centimeter in the upper outer quadrant, extending from 10 o'clock to 11 o'clock position. Irregular in shape. The margins are well defined. Irregular surface, hard in consistency. No other lump in the other quadrants of the breast. Fixity to the skin. It is not fixed. Skin above the swelling is pinchable. Mobility of the lump. It is fixed to the breast tissue, moves along the breast tissue. Fixity to the underlying muscle. It is not fixed. The lump is mobile, not fixed to the underlying muscle, fascia, or chest wall. Skin tetrating is absent. No nipple discharge. Examination of the right axillary lymph node. Single lymph node was palpable in the anterior axilla, which was approximately 2 × 2 centimeter in size, firm in consistency, and mobile. No other lymph nodes were palpable. Examination of right supraclavicular fossa was normal. Examination of the right infraclavicular fossa is normal. On percussion, resonant note over the right parasternal sternum. Examination of the left breast and axilla is normal, sir. Other systemic examination. Respiratory system, bilateral air entry present, normal vesicular breath sounds. Parabdomen, it is soft, non-tender, no organomegaly, no ascites, no other mass palpable. Per vaginal examination was normal. Per rectal, the sphincterome was normal, no rectal deposits. CVS, S1, S2 had no murmurs. CNS, no focal neurological deficits. Summary. A 45-year-old female with a painless progressive lump in the right breast from last 6 months. On examination, a 3 × 3 lump in the upper outer quadrant of the breast. Hard in consistency and irregular surface, not fixed to the underlying muscle and chest wall or the skin, with mobile 2 × 2 centimeter firm lump noted in the right axilla. My diagnosis would be sir, I'll read the diagnosis or I'll wait for the discussions.
No. Tell us what is your diagnosis.
Okay, sir.
What's the probable diagnosis?
It's a case of lump in the right breast suggestive of malignancy with TNM staging, CT2N1M0, stage 2B, sir.
So, ma'am, please take over.
Can you come back to the tell me in your inspection in what positions have you inspected the patient?
Ma'am, first patient was in sitting position, arms by the side.
Right. Then
a patient both the hands raised above the head, and other one is.
Why do we see with the arms raised above the head?
Ma'am, because it will taunt the it will make any obvious swelling prominent, and it will also, if there is any retraction of the nipple or puckering of the skin, it will be prominent in the when the patient
Right.
is
So
standing.
then, okay.
Dr.
Then the
Vishwath,
third position.
wait, just a ma'am, just what are the, like
Yes, sir.
ma'am asked you, what are the things you look for when you in the arm raising test?
Sir, we look for first is inframammary fold, if there is
Right.
any.
Very good.
Next is
You look at
any prominent changes in the nipple areolar complex.
You see the movement of the breast and the NSA of the two breasts. You compare the two, isn't it?
Yes, sir.
Right. Then
We also look for any prominence of the swelling which was not seen in the patient when patient was sitting by the arms by the side, sir. If there's any prominence of the swelling.
okay. Anything else?
Sir, puckering and dimpling, it will become.
No. You look in the axilla also. You can see the axilla also.
Axilla, sir.
So
Axilla.
you see the. So while raising, you see the contour of the breast, how the two breasts move, how the nipple area complex moves. You
Yes.
see the inframammary fold, and you see the axilla.
Yes, sir.
Right, ma'am, please.
Okay, this is the second position. So what about third position?
Third one is patient bending forward, ma'am.
What does this show?
Ma'am, we can see if there is any fixity to the chest wall. Both the breast will not be equally hanging forward, ma'am. There will be restriction of the.
Is it just the chest wall, or do you suppose it's fixed to the pec major? Then also it will not hang. Then,
Sir, that we need to further do the examination to see whether it is fixed to the
so
pectoral.
you don't just say fixity to the chest wall. You say fixity to the underlying structures.
Okay.
If you just say chest wall, what is chest wall?
Sir, chest wall is ribs along with intercostal muscles
And
serratus anterior.
right. So here there's no pec major.
Yes, sir.
So it's just say underlying structures.
Okay.
Right.
What are the palpatory measures you know?
Sir, circle dial method, sir.
Only one method or anything?
Sir, there are two more, sir.
Yeah, tell me.
Other one is a vertical slit
Vertical strip method.
strip method. Another one is
Okay, Dr. Vishwath.
yes, sir.
Why do you have these methods of palpation? What's the idea behind it?
So we can make out the lump.
No, so that you
Should not miss.
palpate all the portions
Yes, sir.
of the breast without missing any.
Okay, sir.
That's the only thing.
Yes,
There
sir.
are many spoke, circumareolar, whatever, all circumder. Okay, you said they're dilated veins.
Yes, sir.
Why are they dilated veins?
Sir, dilated veins is usually seen in other benign conditions also, sir. Benign conditions like fibroadenoma.
So why do the veins get dilated here?
Sir,
You said there must be some importance
yes, sir.
for it. What does it tell you?
So 1 second, sir. There is.
Why will a vein dilate?
Sir, whenever there is increased.
So what happens in malignancy?
Yes,
what
sir.
happens in malignancy?
Sir, there is.
It is very vascular.
Vascular, yes, sir.
So the veins dilate. Right? Sir, please, ma'am.
How do you test for independent mobility of the lump in the breast?
Sir, first we should check the mobility with respect to breast tissue, sir.
Yeah.
First, in one hand, we need to fix the breast tissue and
Very
then try to move the lump along the breast tissue and.
What will happen? What will happen if it is fixed to the surrounding tissue? What will happen if it is not fixed to the surrounding tissue?
If it is not.
Liver test, you have to fix with one hand, no?
Yes,
to
sir.
move with the other hand. What will happen? How you differentiate between fixed to the surrounding structures and freely mobile, independent?
Sir, if it is not fixed to the surrounding tissue, it is mobile, sir, across the direction. Usually seen in fibroadenomas. If it is fixed, then the movement will be only possible along the breast tissues.
It moves the both fingers along with you. What
Yes.
you have fixed, no?
Sir.
It is fixed to the surrounding, it moves along with your moving fingers. Okay.
Yes, sir.
Fixed fingers will move along with your fingers of palpation. Okay. That's the
Yeah.
difference between fixity to the surrounding structure and freely mobile. Okay.
Yes, sir.
Yeah, Dr.
Can you
Vishruth.
come back to the,
Sorry. Yeah, ma'am, please.
can you come back to the slide where it was where you mentioned the size of the tumor?
Yes, ma'am.
How did you measure the size of the tumor?
So vernier
Dr.
scan.
Vishruth? Okay. Why
Or
can't you use a
rather where
tape?
Now I'll go to the palpation 1 second. Yeah,
yeah,
this is the
so go
slide.
to the palpation.
Yes, ma'am.
See, you say it's in the upper outer quadrant extending up to from 10 o'clock to 11 o'clock, right?
Yes, ma'am.
But you have mentioned the distance from the NAC,
I should have mentioned it.
right?
Yes, ma'am. I should have mentioned it.
So what would be the distance from the NAC in your patient?
Ma'am, approximately, I mean, around 6 centimeter from the nipple
Okay.
area complex.
Okay.
Okay. I'll just ask you one question, Dr.
Yes,
Vishruth.
sir.
How do you check for skin fixity? You said the
Sir.
skin is not pinchable.
Yes, sir.
So suppose this is the lump and
Yes,
the
sir.
skin is fixed only at one point. You can pinch it up at the other point,
Yeah. Yes.
right? So what
Yes.
is a better test to look for skin fixity?
Sir, we move the lump to the sideways.
And you
from
see whether the skin moves along with it.
Yes,
That
sir.
sign is called as Plato sign.
Plato sign.
Okay. In your palpation, you said the margins are well defined.
Yes, sir.
In malignancy, do you find well-defined margins?
No, sir.
Why?
The surrounding areas are also continuously getting infiltrated, so the margins will not be well defined.
It's called desmoplastic reaction,
Definitely. Yes.
right? So, but what are the features? So, in palpation, what are the features of malignancy in this patient?
Sir, first it is a irregular surface, sir.
Mhm.
And the shape is irregular, surface is irregular, and consistency is hard, sir.
Right. Okay. Ma'am, please, sir.
What are the differential diagnosis?
Ma'am, at the level of examination, I would keep Phyllodes tumor and carcinomas, malignancy of the breast.
No, your diagnosis, your provisional diagnosis was breast malignancy, breast carcinoma, right?
Yes,
So
malignancy.
in your differential diagnosis, one is Phyllodes tumor. Anything else?
Phyllodes and
Anything else you think of it?
ma'am, giant
Any other conditions which
fibroadenomas.
any other conditions which mimic a breast malignancy?
Ma'am, traumatic fat necrosis.
Okay. Anything
But there
else?
is no trauma. Ma'am, chronic breast abscess or something? Chronic breast abscess or chronic abscess.
A chronic abscess. Can
Yes.
it be granulomatous mastitis?
Yes, ma'am. Yes, ma'am. But then, yes, ma'am. I would keep it as a differential.
Yeah, we'll
Sir,
go ahead
anything?
with it. Management.
Okay. How do you manage this patient now?
Sir, this is stage 2B cancer, sir. So it is the related
Look.
Yes, sir.
Just by examination, you can't say stage 2B.
I would further go for other triple S clinical examination is done. I'd go for radiological investigations, mammogram of bilateral breast, ultrasound of the breast, ultrasound of the axilla, sir. And along with that, I'll also go for tissue biopsy, that is core needle biopsy or FNS.
Okay. So, do you have the reports?
Sir, as of now, I have only the FNSC report of the patient, sir. Core needle biopsies report are yet to be reported.
So, why did you do both FNSC and core biopsy?
Sir, the lump was relatively very small, and the axillary lymph nodes were mobile, sir, and it was very firm, not of hard consistency. So we just wanted to see.
No. Hang on.
You told
Is
us
that the
N0,
reason
no?
why?
Is N0 or
Yes.
N1? N1, okay.
N1, sir.
N1. No. I mean, what's the why? Why did you do both FNAC and core biopsy?
What?
Any
Ideally, it
avoidance?
should have been core needle biopsy, sir.
In other terms, what are the advantage of core biopsy over FNAC? Sorry, is asking that.
No, I'm not. I'm saying you've not done anything wrong.
Yes, sir.
What is the indication for doing an FNAC?
FA.
Sir, FNAC, it is, I mean, advantages of FNAC or core biopsy, sir.
I'm saying what is the indication for FNAC? Is there
Hello?
any indication for FNAC in CA breast?
FNAC. Sir, if actually,
Okay, let's come to what's the difference between FNAC and core biopsy. Let's come to that first. Are you there, Dr. Vishruth? Hello.
Hello?
I think it's disappeared. We've lost this
Hmm.
connection.
Hello.
Ma'ams. Yeah, Vishruth.
Hello, sir. Hello. Can you hear my voice, sir?
Yeah,
Yeah,
we can hear
we
you.
can
Good.
hear you.
Thank goodness you're back.
Sir.
Yeah, tell us the difference between FNAC and core biopsy, please.
Sir, FNAC is we just look for the cytology, sir. In core needle biopsy, we get the tissue sample to look for the diagnosis. In FNAC, we can only see what is the type of cancer. In core needle biopsy, we can do tissue diagnosis along with ER/PR status, HER2 status, and FNAC is relatively cost effective. Core needle biopsy is a bit costly.
No, you said ER2, you get receptor studies in core biopsy.
Yes, sir.
Why do you want a receptor study just now? You can get it once when you have after surgery also can get done. You can send the thing for biopsy there later on, can't you?
Yes, sir. In this case, actually, we can wait till the surgery, sir. If it is advanced breast carcinoma or anything, we would.
Yes. Then it's important.
It's important.
Right. Okay. So what does the FNAC tell you?
Sir, FNAC, it is invasive ductal carcinoma, sir.
FNAC. Do you know the invasiveness in the FNAC?
Sir, actually,
Okay.
FNAC, we cannot differentiate between DCIS and invasive ductal.
How can you say that it's FNAC is invasive cancer? What are the advantage of core biopsy or FNAC?
Sir, FNAC cannot differentiate the
You only told no that is invasive carcinoma in FNAC.
Sir, it is reported in the
How pathologist gives like this in FNAC? Can FNAC differentiate between invasiveness and non-invasive carcinoma in situ?
No, sir.
It is only cytology, no?
Yes, sir. Cytology.
Then who is that pathologist to give like this?
Okay.
Yes,
Let's not name and shame. Yeah. Okay. Right. You've got an FNAC.
Yes, sir.
And it says, or a core biopsy which says invasive ductal carcinoma.
Yes, sir.
Right. Now what do you do?
Sir, it's early breast cancer, so I'd go ahead with. There is a lymph node clinically palpable, sir. So we would just do a ultrasound of the axilla just to see the lymph node, and if possible, I would take a FNAC of the lymph node to plan
So
for.
was it done? Was it done? Not done.
Sir, we are planning. We are doing FNAC of the.
Okay, that's fine. That's fine. Okay.
What is the mammography
So
report? What about the mammography report in your patient?
So mammography, we don't have the facility here. Sir.
It is most important in early breast cancer. No, you have to do mammography.
Yes,
okay.
Sir.
Why do you want to do a mammo there? Why do
So
you want to do a mammo here?
it is done to see any non-palpable lesions in the other breast, in the contralateral breast, sir.
Very good. Very good. Right. Okay. Also, one is that also.
And it
Also, why do you want to get a mammo?
Sir, we can also make out the micro calcification differentiation between the benign and the malignant tumors. There will be micro calcifications, pickled margins.
Okay.
What do you mean by dense
Right.
breast?
Sir, dense breast is
How
it's
they grade in mammogram? Tell me the definition of dense breast and how you grade the readest grade in mammogram.
sir, fibroglandular tissue
Yeah.
is high. In a dense breast, fibroglandular tissues is high, sir. Mammography, the grading is BIRAD's grading, sir. BIRAD 1, 2, 3.
Tell me that.
So BIRAD 1 is it's a negative, sir. BIRAD 2 is a benign lesion. BIRAD 3 is suspicion, probably benign. Biopsy is required. BIRADS 4, it is further divided into 4A, 4B, 4C. 4A has 2 to 10% for suspicion. 4B has 10 to 50%. 4C has.
I didn't ask the risk of malignancy. You know, you tell what is 4A, what is 4B, what is 4C.
Sir, 4A is 0 to 2% suspicion of suspicion.
Low, intermediate, high risk. Okay?
Lower intermediate.
That is enough. The percentage of turning into malignancy, risk of malignancy, I have not asked. Okay. What is 5 and what is 6?
Sir, 5 is breast carcinoma. 6 is the tissue biopsy proven.
Highly suspicious breast cancer to tissue proven. Okay.
Tissue.
Already taking was on treatment. Okay?
Yes. Yes.
Okay. What are the findings of ultrasound and the malignancy?
Sir, your voice is.
What are the malignant? How they look in the ultrasound?
What are the characteristics of a malignant tumor on ultrasound?
Ultrasound.
On ultrasound, sir?
Yeah.
Yes.
Sir, ultrasound, the anterior posterior margins will not be, anterior and posterior margins will not be well made out, sir. And
No, that's not right.
No, that's not the.
Sir, lesions are usually wider, taller than wider, sir, in ultrasound.
Right.
In malignant.
That's right.
Yes.
Margins.
Yes. Anything else?
Irregular margins, sir. Speculated irregular margins.
And calcifications also.
Calcification.
Okay. About axilla, how will malignant lymph nodes on ultrasound?
And ultrasound, sir. Sir, in mammogram, it is oval.
No, ultrasound.
Ultrasound. I'm asking about ultrasound.
What's got the issue? We should.
You have to read and come, no? That's the most important.
Yes.
Okay. What do you think would happen to the lymph nodes if they're malignant? And that's how they look in
general, not only in this case, in general.
Right? What do you think? What would happen to the lymph?
What is the shape of the normal lymph node? How it will become in
Sir, normal shape is kidney shape, sir. They'll become.
They're bean shaped, okay? And so what happens here?
Become what?
Kidney shape. It becomes round in malignant.
Right. So it becomes oval.
Right.
What else? What else?
Sir, hypoechoic. They'll become hypoechoic, sir.
Okay. Anything else? There'll be no hilum.
What about hilum? What about cortex thickness of the cortex? You have to tell all these things now.
Okay. So just go and read about it.
Yes.
Go and read. Okay.
So please.
Vishrut, suppose when you're doing ultrasonography of both the axilla, you find a lymph node in the opposite axilla, which seems to be malignant.
Yes,
you do an FNSC, it turns out to be malignant.
Yes.
So does your staging change?
Yes, ma'am. Stage 4, ma'am. It is metastatic.
It's metastatic. So what is the mode of spread to this lymph node, contralateral lymph nodes? What is the mode of spread?
It could be through internal mammary nodes to the contralateral side, or it could be retrograde from the ipsilateral supraclavicular nodes to the other side.
There are other causes also, Vishrut. It can go through the skin lymphatics, or that could be an obscure or occult tumor in that breast, which has already metastasized to the lymph node.
Yes, sir. Yes, sir.
It's just not that it's metastatic.
Okay.
It can be from the other breast also.
Okay, sir.
Right?
Yes, sir.
What are the theories you know about the progression of the carcinoma breast?
Sir?
What are the theories there
sir.
to assess the progression of the disease, which helps in the management of carcinoma breast.
Progression, sir.
What is Arsted theory? What is Fisher theory? What
Fisher
is
theory, Halstead
spectrum
theory.
theory? Spectrum theory. Based on that only, this chemotherapy and hormonotherapy came into the role. Okay.
Yes, sir.
What are the theories?
Sir. I-
Okay.
I read about it.
We'll
Read about it.
read about it. Okay.
You have to tell and
Yeah, Fisher.
you have to
Right.
take a class for you there.
Okay. So you've done this. You've got this patient who's got a malignant tumor.
Yes,
Now
sir.
what do you do? Now what do you do? She's sitting in front of you with her reports in her hand
Yes, sir.
in your clinic, and what do you do now?
Sir, after all the workups, I'll be doing further workups, sir, as I told earlier. Do the tissue biopsy. Then
You've done all that.
Okay, sir.
You've got the reports. Tissue biopsy is already done.
Sir, I would go ahead with MRM, sir, modified radical mastectomy.
Okay. And she says no.
Sir,
Have you asked her what she wants? Have you counseled her?
okay. We
Have
can
you
do
asked her what
other
it wants?
breast
So what are
conservation.
the options?
Straight away, you will
PCS
do
and,
MRM just because you
MRM.
want to do it. No, you'll suggest MRM just because you want to do it.
Sir.
You are supposed
Axillary
to
nodes
counsel the breast.
Yes, sir. Sir, axillary lymph node, if in the FNAC, if it is shows the primary tumor, then BCS we cannot be. We can give an option with the relative risk.
No.
Vishruth, hang on.
Yes.
Vishruth, hang on. There are two things which are missing, very important. One, that you'll discuss this in the MDT,
Yes,
right?
Yes, sir. Tumor.
In the board.
Yes, sir.
Second, you will counsel the patient.
Yes, sir.
Counsel the patient that this is your condition. This is what we suggest. These are the alternatives.
Okay, sir.
And then move ahead. You can't just say straight away say, I'm going to do MRM. No, it's
Yes.
not right.
Okay, sir.
Yeah.
Is it metastatic workup is needed in your case?
Sir?
Is the metastatic workup is needed in your case?
Yes, sir. Needed, sir.
No. It is early breast cancer. There is no need to do metastatic workup. Okay.
Okay.
How you plan for the management on receptor status? What is luminal A? What is luminal B? How you classify an immunohistochemist depending on the receptor status? How you classify them?
Luminal A is ER/PR positive, HER2 negative, sir. Luminal B is ER/PR triple positive, sir. And
no, so tell me. Luminal B.
What is the difference between luminal A and B? Be clear.
A, what is A, what is B? Again, B's two components are there. What is the difference between second component and first luminal A? Tell me that.
Luminal A is ER/PR positive, HER2 negative, sir.
Very good.
And luminal B, it is ER.
Both same like negative, but one is different. One thing is differentiate between A and B.
Sir, HER2 positive, sir. ER/PR is negative in luminal B.
No.
Anything else along with that?
KI
67. KI 67 is more. It is more than 14% in KI 57. Okay.
Yes.
KI 67. And other?
Sir, HER2 enriched type,
Okay.
sir.
What is that?
Sir, that only HER2 is positive, sir. ER/PR is negative.
Okay.
Then other one is triple negative, sir.
Triple negative. Okay. This your case is.
Yes, sir.
If your case is T2 N0 M0 with ER/PR positive.
Yes, sir.
Receptor negative. Do you subject to the after surgery? Do you give neoadjuvant chemotherapy or not? Adjuvant chemotherapy or not?
No, sir.
How you assess that? No. How can you say that no?
Sir, chemotherapy, we'll see,
How
sir.
you assess that? Patient, there are so many complications by giving chemotherapy. You know, we should avoid that complications by avoiding chemotherapy. How you know that should not give chemotherapy or not? How you know that? In this case,
your case is already clinically N1 positive. N1.
Sir, in this case,
if it is N0, N1 is chemotherapy is 100%. If it is N0, I'm asking.
N0
early breast scan.
In early breast, we'll do sentinel lymph node, sir, if it is born.
What is archetype DX21 gene assay? You have to do that test, no?
Sir. We check for 21 types of gene.
Yeah, what is the test? What is positive, what is negative? Before that, you have to know about HR positive or negative in your case.
Yes, sir.
What is, have you ever seen the HR report? What is negative?
The report
What
is still pending, sir.
have you seen in any patient, not only in this patient?
Yes, sir.
What they give?
Sir, +1. It will take you +3.
No.
Which one is positive?
0, 1, +2, +3. Which is negative, which is positive, which is inconclusive.
Sir, +2 is inconclusive, +3 is positive, sir.
When it is inconclusive, equivocal, what you will do?
Sir, we do FISH, sir.
What do you mean by FISH?
Fluorescent.
In situ.
Fluorescent in situ, sir.
Hybridization. Okay. Then I told you this, you have to do oncotype DX21 gene assay. This is 0 to 100. If it is less than 25, it is negative. If it is more than 25 only, we have to subject the patient for the chemotherapy to avoid the complications of chemotherapy in early breast cancers with the N0. Okay.
Okay, sir.
Again, it depends upon the age also.
Age also.
The stand here, where stand?
Sir? Go ahead.
Okay, if I've heard right, you said that if the lymph node is positive,
yes, ma'am,
then you cannot go for BCS.
No, ma'am. If lymph node is positive, we'll have to go for MRI.
What are the indications? What are the contraindications to breast conservation?
Ma'am, first is if tumor size is more than 5 centimeter, or if we cannot maintain the positive margin, if there is a cosmetically unacceptable defect after doing breast BCS.
Unacceptable to whom?
Patient, sir. To the patient.
No, patient cannot decide on that. It's all not a contraindication. This you cannot put as a contraindication for this. What are the absolute contraindication when you say that I will not do BCS?
Absolute contraindication is pregnancy, sir. And other one is if there is any previous history of radiotherapy to the chest, radiotherapy irradiation, or if there are 2 or more separate mass in the same breast, 2 or more separate lump in the same breast, sir.
Multicentric or multifocal?
Sir, multicentric, sir. Another one would be persistent positive margin, any positive margin if it is there.
So N1 is there, is it a contraindication?
N1, yes. It's not an absolute contraindication, sir, but
it is not even a contraindication. Not absolute or relative. It is not a contraindication. So always the management of the breast carcinoma, it is breast separately. You are going to do the axilla
dissection also.
Systemic separately.
Okay, sir.
For the breast, you can do a breast conservation. Axilla, again, depending upon your whether sentinel or whatever way you can manage.
Can you be able to tell what is N1, what is N2, what is N3?
Sir, N1 is non-mobile lymph nodes present, sir. N2 is matted lymph nodes.
What do you mean by matted? What do you mean by matted node?
Sir, two or more nodes coalesced together is called.
What does it indicate? Is it a perinodal infection like periodinitis, which is happening in the tuberculosis? Can they get matted?
Yes.
What is it called? In malignancy, if the nodes get stuck to each other, what is it called? It's called ENE, extranodal extension.
Okay, sir.
Yeah.
What is N2? N2, A and B.
Sir, and N2 is ipsilateral, sir. Ipsilateral level 1, level 2 axillary lymph nodes fixed or matted, sir.
Yeah. B.
N2B is sir, internal memory, sir.
Simple thing to remember is N1 is mobile. Okay.
Yes, sir.
N2A is fixed.
Fixed.
N2B is internal memory.
Yes, sir.
N3A is
Infraclavicular.
N3C is supraclavicular, and B is both A plus B.
Okay,
N2A and B. Okay, that is simple as that. Don't
Yes, sir.
forget in your future. Okay.
Yes, sir.
Okay.
Can I
Okay,
ask a
Dr.
question,
Vishnu.
sir?
Please, sir.
Yeah. What are the contraindications for radiotherapy in conservative breast surgery? What condition would you look for in a female patient?
So, pregnant women are
Pregnancy. What else?
Is
sir,
it the entire period of pregnancy is contraindicated?
for radiotherapy, yes, sir. After the
Oh, see, what is the duration you can take to give a radiotherapy? After your surgery, within the 6 months, you can complete the radiotherapy. So, if the patient is in the third stage of the third trimester,
yes, sir.
you can still
How do
do
you
breast
how do you
conservative.
manage pregnancy with breast cancer?
Sir, we can plan breast conservative surgery in second trimester along with chemotherapy in the second trimester, sir. By the third trimester, after the delivery, we can start radiotherapy, sir.
No, actually nowadays radiotherapy is so precise
Yes, sir.
that this system or business of pregnancy and RTs is
All
slowly
gone.
getting narrowed, right?
Okay, sir.
And you can use it. Sometimes they use a mantle also to cover and do it.
Okay, sir.
So we still go say that they say that RT is continuing, but the thing is getting very narrowed down now.
Okay, sir.
So, what will be the investigation you do when you have suspect pregnancy? You prefer MRI or any
Yep.
investigation?
MRI, sir. MRI, sir.
MRI? So, what it will give?
Sir?
No, why do you want to do MRI for the breast
Sir,
pregnancy?
Sir, no radiation exposure is one.
Why
Otherwise,
should you need a radiation exposure? Is it not a mammogram is good enough?
mammogram.
MRI is not indicated.
Okay.
In the pregnancy, unnecessarily putting the mother into that room for long hours. And
Okay.
it is going to give you a lot of misvalue because the blood congestions there, the concentration will be different. It will give a false value of the multicentricity.
Okay,
So
sir.
preferably not to do MRI in a patient with the pregnancy.
Yes, sir.
What is the importance of collagen vascular diseases in breast cancer?
Sir, we cannot give radiotherapy to such patients.
Yeah, that is also an absolute contraindication to
Contraindication.
conservative breast surgery.
Yes, sir.
What was COT therapy?
Sir, quadrantectomy with axillary dissection followed by radiotherapy, sir.
Yeah. What is being done now? What is oncoplastic breast surgery?
Sir, oncoplastic breast surgery, there are two types, sir. Displacement and displacement surgery, sir. Displacement and
replacement.
Replacement surgery. Yes, sir. If the size of the defect is less than 10%, we do displacement displacement procedure. If it is more than that, we'll go for replacement, sir.
Are central breast tumors a contraindication to conservative breast therapy?
Central breast tumors. No.
So if it is just in the areolar region, retroareolar region.
Yes, sir.
So how will you do the breast conservative surgery? You must answer. Even you can do, and you will reconstruct the nipple, and you give all the oncoplastical procedure. But generally,
you can.
Okay, sir.
Okay, sir. Anything else? Should we close and call in the next case, sir? Dr.
Yeah.
Jailer?
Yes, sir. Yes, sir. Please.
Right. Okay, Vishwat, anything you want to clarify before we call the next person? Anything about? Okay, well done then.
Okay, thanks.
Who's the next
Sir, I would
person?
like to thank my guide, Dr. Nishikant sir, and HOD, and all the
That's very generous.
Dr. Kananvel sir for giving me opportunity to present a case here, and all the professors here for helping me, guiding me with all the knowledge they have. And I would also thank my HOD Sajid Mulur sir and Dr. Chilani sir for allowing me to present a case.
Good, good.
That's
Thank
very
you, sir.
generous.
Thank you, sir.
Very nice. Thank you. Well done. Okay, the next presenter is what's the next presenter? Vinaya Deepa, is it? I'm not sure. Let me have a look. Okay. Parotid tumor, Sushma, Dr. Sushma, are you there?
Yeah, she is
Yes,
there.
sir. I'm here.
Dr. Sushma?
Yes, sir. Can you hear me?
Yeah, let's see your face. Yeah, good. And now let's see your slides. Yeah, good. Make it a slideshow, please. Yeah, good. Go on, please. All the best. क्लास में हम करें बात आएगा अब
So can I start?
Yes, go ahead.
Good evening, esteemed faculties present here and my dear colleagues. I'm going to present a case of swelling in the right parotid region under the guidance of Professor Dr. B. Shanti, Director, Institute of General Surgery, Madras Medical College, and myself, Sushma, a second year graduate, Institute of General Surgery. Mr. X, a 58-year-old male, resident of Chennai, daily wager by occupation, came with complaints of swelling in the right side upper part of neck for 5 years. History of presenting illness. The patient was apparently normal 5 years back when he noticed a swelling in the right side upper part of neck, which was insidious in onset, initially small in size, approximately 1 × 1 centimeter, and gradually progressed to a current size of approximately 2 × 2 centimeter. The swelling not associated with pain, no history of fever, no history of ear pain, no history of variation in size of the swelling with food intake, no history of difficulty in opening the mouth, no history of suggestive of facial nerve palsy, no history of rapid increase in size of swelling, no history of ulceration of overlying skin, no history of dryness of mouth or eye, no history of joint pain, no history of cough with hematemesis, no history of oral ulcers, no history of any other swelling in the head and neck region, and no history of ulcer or swelling in the scalp. Past history, there's no history of similar complaints, which is the swelling, no history of previous surgery, no history of previous irradiation history, comorbidities. He's a known case of systemic hypertension for 5 years on regular medication, and not a known case of diabetes mellitus, TB, chronic liver disease, or HIV. Personal history, the non-vegetarian smoker for the past 20 years, consumes alcohol occasionally for the past 10 years, with a normal bowel and bladder habits, normal sleep cycle. So the summary, a 58-year-old male who is a chronic smoker came with complaints of swelling in the right side upper part of neck for 5 years, which is gradually increasing in size with no other significant history.
So you were noticed the swelling of only 1 centimeter size, no? Where he noticed the swelling?
Go to second slide.
No, you have said patient has noticed the swelling at 1 into 1 centimeter. Where he noted the swelling?
Because of the
No. Where was the swelling?
in the right side upper part of neck, close to the
Can you put it in a better term?
below the ear.
What is parotid region?
It is a region enclosed within the zygomatic arc, the line joining the angle of mandible and the posterior belly of digastric. Posteriorly, it's the mastoid process, and anteriorly, it's the
So you are postgraduate, you are presenting. So you must say that I have noticed a swelling in the parotid region. Don't beat around the bush. You can straight away put that swelling as notice, and it has increased. And
Tell
the
me
5
the
years
exact-
it has grown only double the size.
Excuse me, sir. Tell me the exact boundaries of parotid region.
Yeah.
Anteriorly, it's the posterior border of the mandible, joining the midpoint of the zygomatic arch. Posteriorly, it's the mastoid process. Superiorly, it's the zygomatic arch, and inferiorly, it's the posterior belly of digastric
No,
and
no,
the angle of
no, no,
mandible.
no. You're telling wrong.
The inferior border of mandible.
Inferior border of the mandible. Anteriorly and posteriorly. Anteriorly what? Posteriorly.
Anteriorly, it's the midpoint of zygomatic arch.
No. Masseter. Anteriorly, masseter. Posteriorly, posterior superior and posterior inferior. They have. What is posterior inferior borders? What are the posterior superior borders?
There's a mastoid and the posterior belly of digastric.
External acoustic meatus and zygomatic arch are posterior superiorly, inferiorly, mastoid process and sternal mastoid head of the sternocleidomastoid. Okay?
Yes, sir.
Sir, Jailal sir, go ahead.
Yeah, go ahead. No, you have seen that it's a size in the 5 years, it has increased in the size.
Yes, sir.
Okay. You have asked for the variation of swelling in the food intake when you are taking the variation in size of the swelling with food intake. What do you mean by that?
Sir, it could be style adenitis.
Why you have asked that question?
A chronic style adenosis can also be present with a swelling that could gradually improve. Here, whenever the patient has a food intake, there is increase in the size of swelling.
Is it when he takes the food you are asking, or anything more than that?
So with the
Suppose he is going to the dining hall, he is not taking the food.
with the smell, with the sense.
So it is gustatory. It is not that only when he is taking the food. Why the size can. Yeah.
1 minute. What is the difference between gustatory sweating and gustatory pain? In which conditions you will get gustatory sweating?
Happens in Frey syndrome.
What do you mean that?
Huh?
What do you mean by that?
It is when it happens in a post-operative condition of parotidectomy, where the auricular temporal nerve, the posterior postganglionic parasympathetic fibers, innervates the skin over the angle of mandible, where when the patient has a sense of smell or it has a food intake.
No.
What will happen in Frey syndrome? What you have told is postganglionic parasympathetic fibers. What will happen in parotid surgery? What will happen?
There is innervation of those fibers with the sympathetic fibers, and they innervate the nerve.
They replace the function of which nerves?
You have said
they overtake the function of some nerves. No, this parasympathetic change. Sympathetic change supplies which part of?
Why sympathetic produce sweating?
Sympathetic, they supply some organs in the skin, no? So what structures
Dr. Sushma, I'll just put it plainly for you. What sir is trying to say that there are two systems. You have the parasympathetic and the sympathetic, right?
Yes, sir.
The parasympathetic is coming from your facial and is joining the sympathetic portion of the skin. So he's asking what is that portion of the skin, sympathetic portion of the skin, which is joining to? What are the structures which lead to sweating in skin?
Sweat.
Sweat glands, sweat glands,
Sweat
sweat
glands,
glands,
okay.
sweat glands.
So
What
it
will
is,
that is what is gustatory pain?
It happens in sialidinosis when there is increased
Other than
salivation.
sialidinosis, in which condition you will get gustatory pain? In other words, what is first bite syndrome?
It is a neuromuscular condition, sir, where
What is
when
first bite
the-
syndrome? What will happen in first bite syndrome?
when the
Here
patient
they think of food, they will get a sweating in face syndrome. Here they have to chew. They will get some pain. Where they get they feel pain in first bite syndrome?
temporomandibular.
Preauricular region they get pain. What is the reason for that? Here is postganglionic parasynaptic fibers are damaged. Here is the exactly opposite. Here sympathetic fibers are damaged. Okay.
Yes, sir.
In which conditions the sympathetic fibers are damaged to the parotid? In post surgeries, tell me the in which surgeries the first bite syndrome will happen. You have to read and come, no?
Okay, let's get back to your history.
Okay.
You said no history of pain. Okay, no, what was your differential diagnosis after history, Dr. Shushma?
I think we are,
Sir, it could be any benign condition of skin like lipoma. It could be dermoid sebaceous
No.
cyst, or it could be parotid
No, yes.
swelling, benign parotid swelling, or it
Yeah.
could be a cervical lymphadenopathy.
So, Dr. Shushma, don't give me a whole list of all the structures which are out there. Just give me the most probable ones. What's the first
It could be a benign
differential?
parotid swelling, or it could be
That's
a
it.
cervical lymphadenopathy.
cervical lymphadenopathy.
How you differentiate between cervical lymphadenopathy and the parotid swelling?
With the obliteration of the retromandibular.
No,
Very
no, no. No, cervical lymphadenopathy you are talking about. That is level 1. Which level you are talking about?
It's, level 2 or the level 1B. sir.
ఓ కరెక్ట్ మన చిన్న బెడ్రూమ్ లో పోతే ఉంటుండే.
Can you differentiate a parotid lymph node in the parotid and
అయ్యో మర్చిపోయాను రేపు పోయినప్పుడు
and parotid swelling?
Tell to Ravinder sir to mute, sir. He is
Or
disturbing.
చిన్న బెడ్రూమ్.
Tell to Ravinder sir to mute. Sir, Kangavel sir.
No, he is not able to mean.
Kangavel sir, please. He is disturbing
Ravindran
Ravinder from Karimnagar, sir.
Rao sir, please mute yourself.
He is from Karimnagar, Telangana. How you differentiate between paraglandular lymph node from the parotid gland? Sir is asking, Jalal sir asking. Not from cervical lymph node.
it is the groove in between the tragus and the parotid gland, sir.
No,
In
that area
preauricular-
is preauricular lymph node.
Hmm.
When you have a preauricular lymph node, how will you differentiate? What is curtain sign?
Yes, sir. In the case of parotid swelling, the curtain sign, the swelling cannot be lifted above the zygomatic arch.
What is zygomatic arch?
So it is a extension of maxilla.
No. So it is not
Okay.
formed in the
So
simple
why-
bone. It is a process.
Why can't? Yeah, it's process. Okay, why can't you push this parotid swelling beyond the zygomatic, and the preauricular lymph nodes can go beyond it?
So it is because of the investing layer of that covers the parotid, sir. The investing layer
What
divides into 2 parts.
What layer? Investing layer of what?
Deep cervical fascia.
Very good. What will happen?
Right.
How you divide?
Into superficial and deep investing layer. The superficial layer gets attached to
Superficial
the
lamina,
inferior-
deep lamina, not investing layer. The superficial lamina,
The
and deep lamina.
superficial lamina attaches itself to the inferior border of zygomatic arch, and the posterior one attaches to the base of skull. So this limits the movement of the swelling above the zygomatic arch.
What about the deep lamina?
The parotid will not move, but the preauricular lymph nodes which are lying
Lymph node moves.
outside the thing
Can
can
move.
move.
Have you differentiate between the lymph node of cervical lymph node and parotid?
So one thing can be obliteration of
There's a
the
level 2 lymph node and parotid. I am asking about to differentiate between level 2 lymph node and parotid.
Lifting of the earlobes, that could be.
No, no.
Level 2 will not go there, no?
Level 2,
Fine.
how can they go to level? You
What
have
is,
to
the, what is the relation to the sternocleidomastoid?
Yeah, that's one is that one. One is if you move that, it won't move above the mandible. One is if you contract the sternocleidomastoid, it will become less prominent. That is the difference. Okay.
You said there is no difficulty in opening the mouth. You asked for what reason?
One thing, it could be any oral malignancies that could be there, or it could be extension of the
in addition
swelling.
to this only, you are expecting a oral malignancy.
It can be, sir.
No.
Okay.
No. When the base.
Which muscle is responsible for opening the mouth?
Okay.
Lateral pterygoid.
So can you trace these layers of the cheek, the parotid region layers from the skin to mucosa?
It's skin, platysma, the subcutaneous muscle
the parotid region, you are going to get a platysma.
It's a subcutaneous muscle aponeurotic layer.
Okay, smash.
Then it's the investing layers, superficial, parotid. Then behind it, it's the buccopharyngeal, superior constrictor, pharyngobasilar.
Superior constrictor.
Yes, sir.
Which superior constrictor comes there? We have two muscles, which is not superior constrictor. One is masseter, one is vaccinator. Pharyngobasilar fascia, buccopharyngeal fascia. Yeah. Okay, go ahead. Go and read, because that is important. The layers of the how it goes, where the parotid duct is coming, all that is important. Go ahead.
Okay, Dr.
I think you
Sushma.
continue with the palpation part.
Yeah, come to the part.
No, I just want to ask you, Dr. Sushma. You said there's a benign, it could be a benign parotid tumor, right? 58-year-old man with the chronic smoking. What do you think could be the pathology?
So it could most probably be a Watten's tumor.
Right. So, what are the characteristics of Watten's here?
That is slow growing, soft.
Your patient is a male or female?
Male, sir.
Males.
Oh, okay.
So
elderly
male with smoking.
Smoking. Yeah.
With a tumor which can be usually in the lower pole of the parotid, can be bilateral, and has a hotspot on technetium scan. Okay, right. Should we go to the examination, please, sir?
In which race do you see Watten's tumor? Is it seen in all races?
Common in white.
Caucasians. More common in Caucasians. It's very rare in Asians and South Asians and Negroes. So don't make a diagnosis of Wharton tumor as your first possibility.
Okay, sir.
Go for the examination, ma'am.
General examination. The patient is examined in well-lit room and consent has been obtained. Patient is conscious and oriented to time, place, and person. Patient is well-built and nourished. No pallor, ictus, cyanosis, clubbing, pedal edema, and generalized lymphadenopathy. Vitals are stable. With local examination, inspection, a single swelling of a size approximately 2 + 2 centimeters, seen behind and below the right ear. Ovoid in shape, surface appears smooth, margins ill-defined, extending anteriorly 1 centimeter in front of and 2 centimeter below tragus, posteriorly 2 centimeter anterior to mastoid, inferiorly 1 centimeter above angle of mandible. The retromandibular groove is obliterated, skin over the swelling is normal. No lifting of ear lobule by the swelling. Swelling does not become prominent with clenching of teeth. No swelling in the left parotid region, no other visible swelling in neck, and no history of discharge from Stenson's duct. Oral cavity examination, the nose trismus, oral hygiene is fair. Lips, buccal mucosa, alveolar, tongue, floor of mouth, retromandibular trigone, palate, tonsil of fossa, posterior pharyngeal wall appears normal. No fullness present in right tonsil of fossa. Opening of stencil duct appears normal. Palpation, no warmth or tenderness over the swelling. A single swelling of size 3+2 centimeter behind and below the right ear, ovoid in shape, extending 1 centimeter anterior to mastoid till anteriorly 1 centimeter in front of 2 centimeter below tragus, 1 centimeter above angle of mandible. Borders well defined. Surface smooth, soft in consistency. Skin over the swelling is free. Curtain sign negative. Bidigital examination of parotid duct is normal with the deep lobe not palpable. The facial nerve examination is normal. The neck examination of neck, there is no cervical lymphadenopathy. Examination of other salivary gland is normal, and examination of scalp is normal. With systemic examination, CVS S1 has to heard, respiratory system bilateral entry present. For abdomen, soft bowel sounds heard, and CNS is no functional neurological deficit. So provisional diagnosis is benign tumor involving right parotid, probably Watten's tumor.
How did you examine the parotid duct?
Sir, one, it could be the method where you clench the teeth and in the mid 1/3 of line joining the tragus and the angle
You have put as a bidigital examination you have done. You have marked as you have done parotid duct by bidigital examination.
So you can also do
No, accepted method is you put the muscle into clench and roll it over. That is the best method to do.
Yes, sir.
And you also said you have examined for the clenching the teeth and swelling in the
for the prominence of the swelling.
Why?
So to see if there is infiltrate, like one thing it could be parotid swelling where it's above it.
If the parotid swelling on the clenching the tooth, what will happen?
The masseter contracts, so the swelling, if it involves the masseter, will become prominent, whereas the swelling above it will become less prominent.
No. If after masseter contract, it will become more prominent. It is superficial to masseter. How you know the plane of the swelling due to deep fascia? Which test you will do to know the plane of the swelling which is deep to the deep fascia, this parotid, deep to the parotid fascia? What test will know that it is deep to deep fascia? It will become less prominent. What you have to do one test. How you no. What test you will do for to look for the plane of the swelling? Is it deep to deep fascia? No, for thyroid you will do some test. This also you have to do one test. In which test the deep fascia is tested? You have to open the mouth. If you open the mouth, the deep fascia will stretch and it will become less prominent. Okay.
Suppose on clenching the tooth, your swelling becomes bluish discoloration. Is it indicate anything? Have you heard the turkey wattle sign? So if it is a hemangioma, rare tumor, hemangioma, like a clenching the tooth. But otherwise, you will not go for checking this. Opening the mouth, you can see the plane, but not clenching that you cannot see the increase in size and other things. Okay.
So why do you think this is a parotid tumor, not a lymph node? What makes you think so?
Ma'am, first the region, ma'am, it involves a parotid region. Second thing is the obliteration of retromandibular.
Does it involve the parotid region in your examination?
Does it involve all, ma'am? Ma'am, can you please repeat the question?
Does it involve exact parotid region in your examination?
It mostly involves the lower part of the parotid.
So how do you differentiate?
Consistency is one point.
You said soft consistency. What does that mean?
Mostly like cystic glandular involvement.
You tell the answer, madam. Don't drag.
No, what I was trying to say that she said it is a soft consistency. Exactly, is it obliterating the angle of the behind the groove behind the mandible?
Yes, ma'am.
Retromandibular groove.
Retromandibular groove is obliterated, she said.
Yes, ma'am.
Dr.
Have you test for a deep lobe? Have you palpate a deep lobe?
Yeah, that is the question I wanted to ask. Yeah.
So
will
it's
you able to
bidigital
palpate the deep lobe?
examination where the index finger of right hand has to be kept at the tonsillar fossa, and
you will gag the patient. And you will gag the patient.
And he will
there is,
bite your
Bite
hand.
your finger.
if there is prominence of
Can you palpate a normal deep lobe?
no, sir.
No. On inspection,
What will be the finding?
what do you see? What is the finding if the deep lobe is involved?
So when you open like the tonsillar fossa will be pushed medially. Sir.
On inspection, what do you look other than this tonsillar fossa for in a parotid case?
Deep lobe, sir.
No.
No, oral cavity inside.
Other and oral cavity pertaining to your case, one is you have to look for the tonsillar fossa deviation. One another thing is
Opening of Stenson's duct can be
opening of Stenson's duct. Okay.
Where you have seen?
Is there any discharge?
Opposite. No, sir.
Okay. Where do you look for the opening of the Stenson's duct?
Opposite the crown of upper second molar tooth.
Okay.
You have
What
seen
is the
opening you have seen?
Sir?
You have seen the opening or not?
We haven't, like, I haven't seen.
And how do you say that there is the opening is normal?
No.
So
You
with
have not seen. That means that you are not looked for. And one small mistake which we repeatedly say, the Solly never use the word no warmth. We are always warm. We are all warm-blooded animals, not the cold-blooded animals.
In one more condition, we look for the same site, that is upper second molar. What is the condition? Some spots will be seen. Which condition?
Complex.
In which condition?
Mumps.
No. It is measles.
Measles.
Measles, sorry, sir.
What is surface marking of the parotid duct? Surface marking of the parotid.
Origins from the anterior border of.
I am asking about the surface marking, not origin. Surface. How you mark on surface of the skin?
So it's the mid 1/3 of line joining the tragus and the angle of mandible.
No. Tragus and angle of the mandible. Is there tragus? Here is the angle of the mandible. You draw a line there here, from here to here. You have to draw. Have you seen my face? You have to draw a line from the ala of the nose to the angle of the mouth. Imaginary line. One more from tragus to the midpoint of this line, first line. Okay. In the middle 1/3 is the parotid duct. That is no. You have not seen this in any book. Okay. This is the you write down. You have to draw the line from the ala of the nose to the angle of the mouth. First imaginary, second imaginary from the tragus to this line. Draw in the center of the middle 1/3 is the parotid duct. Okay. Sir, go ahead, sir. Jealous.
Okay.
Sahai, sir.
No. In the previous slide, inspection you have seen the posterior pharyngeal wall. How did you saw the posterior pharyngeal wall?
Or indirect laryngoscopy.
You are used indirect laryngoscopy.
Through.
Have you examined postgraduate? Please in the examination. If you would have not examined, we are not going to find fault with you. But don't come and commit, say that I have examined posterior pharyngeal wall is normal. All that without examining. Can you tell the boundary of the retromolar trigone? And you have not set the tooth formula. He's a relatively old man, no? It's the teeth and where the teeth are there, which tooth is not present, that is the pressure, that up, right up, and that also you have to put. And what you have really seen, you see. That is nothing. We have given only 45 minutes for you to examination. We don't expect you to examine everything. Okay. Why you look for no other visible swelling in the neck and other region? What is your intention of looking for?
So one is to check the opposite parotid if it's normal or if there is a bilateral parotid swelling. Another one, if there is any node involvement.
So multiple nodes are, multiple glands are involved?
To check for if other salivary gland involvement and.
So what do you suspect?
There could be, in case of malignancy, it could be lymphoma or it could be an autoimmune condition.
Which condition?
Muculex, where there's enlargement of salivary glands, and there could be Sjogren's syndrome.
So both are autoimmune.
Yes, sir.
So then what is the difference between Muculex and Sjogren's disease?
There's a clinical presentation.
Will be same. Clinical presentation will be same.
Yes, sir, with the involvement of joint arthritis in Sjogren's.
Sjogren's syndrome. When the gland is involved in the Sjogren's or the Muculex, is there is any difference in the gland, in the structure, in any antibodies present?
Antibodies is present in Sjogren's.
Okay, in the Muculex there is no antibodies. That means it is not an autoimmune.
Autoimmune.
Okay, so and the Sjogren's, it is irreparable damage to that. Apoptosis will be there. Muculex, it is a reversible condition. So you must know that it's not that the same you are going to talk about.
How do you look for xerophthalmia in Sjogren's and Muculex and Goodwin's? What test you will do to it's negative or positive for xerophthalmia?
West Bengal test.
Huh?
The one is that Rose Bengal test in a tissue.
To know either dry eyes or wet eyes, what test you will do, Amma? Skimmer's test. What is negative? What is positive? Is it Skimmer's test? No. Then it is when do you say it is positive? When do you say it is negative? Okay.
Yeah.
Okay. Dr. Sushma, how do you manage this patient?
I would like to proceed with an ultrasonogram of neck, followed by UST guided FNEC.
Do you need an FNEC? Why do you want an FNEC?
Find out the pathological histopathology of the swelling. Sir.
Does that change your surgery? Does that change your management? It doesn't.
A high grade.
It doesn't. It doesn't. You think it's. How will you clinically know this is a benign condition? What are the features clinically you find if the thing was malignant?
There's a rapid growth of the tumor. There could be infiltration into the surrounding structures like skin. There could be.
Dr. Sushma, give us the most obvious answer first. Involvement of facial nerve.
Important note there.
Right. Second would be lymph nodes.
I think
involvement of surrounding structures, metastasis, all that doesn't happen here. Very right. Okay.
Sushma, are you aware of the term metastatic pleomorphic adenoma? Pleomorphic adenoma is a benign tumor, but it can produce metastasis, even locally or distally. So go and read that one article on metastatic pleomorphic adenoma. Okay.
FNA has a role in the parotid, like thyroid. There is a Bethesda classification is there. In parotid, also one more class reporting system is there. What is that?
Milan's classification.
What is that Milan's reporting system? What is category 1? What is category 2? What is?
Category 1 is non-diagnostic.
Okay.
Category 2 is non-malignant. Category 3 is AUS, ATP of uncertain significance. Category 4 is benign. 4A is benign and 4B is salivary gland of
Sump. You have to sump. Salivary gland tumor of uncertain malignancy.
Malignancy. 5 is suspicious of malignancy and
Uncertain
6
progression.
is malignancy.
Very good. FNS has a role. Near Bail 28th edition, they gave about the Milan's classification. Go and read, okay?
Yes.
Okay, will you do a FNS in this patient or not? Let's come to that point. And if yes, why? If no, why? You don't. It's obviously that your patient has a benign. You're going to go in with superficial pattern. What other information do you want from FNAC? What do you think is your tumor? Is the commonest tumor here? What is the commonest tumor here?
Warthin's tumor.
No.
Pleomorphic
Well,
adenoma is
it's not very common.
Pleomorphic adenoma is the commonest tumor.
Yes, sir.
What will be the histology in pleomorphic adenoma?
It's
How will you read that slide?
Why is it called pleomorphic? Let's come to that. Or why is it called mixed pattern?
It's both solid and cystic component.
No.
That is not on the histology.
That is the not answer.
Sorry,
Varied
I was given a
morphology of
clue for
cells.
you. It is
No.
called mixed parotid. What kind of tissue will be there? You are going to get an epithelial tissue only or anything else?
Other than epithelial tissue.
It has epithelial, myoepithelial,
myoepithelial.
stromal.
Mixed up.
So see, you must now you should read the histology. Whenever you are getting a diagnosis as a pleomorphic adenoma, don't study only the impression. What is being described, that is more important, but you must see that why you are going to say that this is pleomorphic adenoma.
The difference between what is the difference between pleomorphic adenoma and Warthin's tumor on biopsy? Sir asked, Jalal sir asked. They asked only pleomorphic. I am asking about the difference between Warthin's and this.
Warthin's there be oncocytic cells with lymphoid background.
No. Columnar projections will be there. Cystic columnar epithelium with papillary projections will be there in Warthin's tumor. This is homogeneous. This is heterogeneous. Calcifications seen in pleomorphic adenoma. Calcifications are not seen in Warthin's tumor. These are the differences. Every examiner will ask this. Okay.
These 3 points are the very valid points. I mean, you must remember that. Okay. So you have now come to a conclusion. It is a pleomorphic adenoma. The facial nerve is not involved. Okay. So how you are going to proceed?
If it's a pleomorphic adenoma not involving facial nerve, I'll go ahead with superficial parotidectomies.
What are the surgeries you know? First, tell me the surgeries you know for parotid.
Extracapsular
Recent, include the recent advances also. Okay.
Extracapsular parotidectomy, superficial, total conservative parotidectomy, and radical parotidectomy.
Very good. What is extracapsular excision? Why we should do extracapsular?
Fascia.
Why we should do extracapsular rather than enucleation? What is the
logic behind
that? We should
seedling.
include normal tissue also. Okay. What is the rationale behind that? What is pseudopodia?
Enucleation.
Pseudopodia is seen in.
Why is pseudopodia? I only gave it, sir.
That's an extension.
That's why we had the pseudopodia may invades the capsule and extends the normal tissue. What is the advantage of extracapsular excision over the superficial parotidectomy?
Preservation of the nerve and.
What is the advantage? Why they have invented this procedure instead of going for superficial parotidectomy?
The preservation of facial nerve will be better in.
We can prevent the injury to the facial nerve. Okay, can prevent the injury to the facial nerve. What are the complications of superficial parotidectomy?
So there could initially there could be hematoma hemorrhage formation post complication, and there could be injury to facial nerve.
Hemorrhage, very rare in parotid surgery. Hematoma. Chance of hematoma is very rare. Seroma, you have to tell seroma.
Seroma.
Okay. Before that, you have to tell one thing. What is lazy S insertion and what is modified Bayes insertion? What are the advantages of modified Bayes over the lazy S insertion? To prevent something, they have invented these procedures. What to prevent? Post-op complication it prevents.
Greater auricular nerve.
No. Flap necrosis. One of the most dreaded complication of parotid surgery is flap necrosis.
All
But
starts
that's
with
why-
F.
Tell
All the complication you can start with the F. Flap necrosis, Fry's syndrome, facial nerve injury,
yes, all starts with F.
fluid retention. Okay.
What is the other complication?
Facial nerve injury, face syndrome.
How you treat facial nerve injury on table? How you treat facial nerve injury on table? You have done injury to the facial nerve, cut the facial nerve. What will you do? Rajesh sir will tell. We should not do anything. You have to call for the plastic surgeon. We have to call for.
What is the? I mean, at least the plan. You should know what is the plan.
What is the plan?
Graft, neural graft can be kept.
You must always have a plan A, B. No, you are seeing that it's cut, or when you are seeing there's a large portion is lost. And depends upon that only what treatment is
Cable
going
grafting
to be.
or.
It is the amount of nerve which is lost.
Lost.
So more than 2 centimeters, less than 2 centimeters. Now what do you do?
More than 2 centimeters, you can join the cut ends. And also,
More than 2 you join primarily.
Less than 2 you can join, and more than 2 you can use a graft. Either a single graft or a cable graft.
What is a cable graft?
Cable graft is like multiple nerve grafts joined together.
So which nerve you will choose? Which nerve you will choose?
Sir, either great auricular nerve or Suran nerves.
So you don't want to great auricular nerve. You can sacrifice it.
Anterior part you can sacrifice.
Anterior part.
Okay. What about what after surgery you find that next morning the patient has facial palsy? What do you do now?
It could be initial neuropraxia, sir. So we can start off with corticosteroids for the patient.
What is neuropraxia?
It is just the capsular stretching that causes nerve injury.
What is neuropraxia? What is oxynotomesis? What is neurotomesis?
Neurotomesis is when.
What we say, but what is neuropraxia?
It's just the stretching of the nerve sheath, like nerve sheaths.
What is concussion? What is concussion?
Okay, sir.
What is the structure of a nerve? Shushma?
It's multiple axons forming nerve bundle joined together by perineural sheath.
Perineural sheath.
Like 3 layers.
What are the layers?
What is epineurium, perineurium, endoneurium?
Epineurium is when.
Okay, you can go and read all those things. Okay.
Okay. Yeah.
So how will you identify the facial nerve during surgery?
So it's you can identify the tragal point, and 1 centimeter below and medial to it is the trunk of facial nerve. Otherwise, you can identify the stylomastoid process and down beneath.
Dr. Shushma, have you seen a parotid surgery, superficial parotidectomy?
Yes, sir.
Okay. How did the surgeon identify the facial nerve?
Using tragal points.
How will you
They use the tragal point?
How deep it is the tragal point?
So from the tragal point, it's 1 centimeter.
No. Where is tragal point?
It's a cartilage is 1/3 and the bony meatus.
It's a junction
It's
between
the-
cartilage and bony.
No.
The junction, tragal point.
Yes, sir.
It's usually not used. It says in theory, but most
Common-
surgeons don't use that.
Yeah. Commonly, what
They
procedure
use-
they will use? Common procedure to identify the facial neuroma. Sir is asking. You have
Either
to-
anterograde or retrograde method, sir.
No. Retrograde is very rare. You have to identify some belly,
Muscles.
some belly.
Of the muscles.
Following the anterior margin of the posterior belly.
No,
of the
belly.
Which belly?
Which belly?
Posterior belly of the.
How will you identify, ma?
So it's the fibers. You identify the sternocleidomastoid
Okay, good.
and the fibers opposite, running opposite to it.
Opposite, not. Okay. You identify. Any arteries will be there near the facial nerve?
Superficial temporal external carotid arteries.
No.
External carotid artery.
Beneath it.
No, I am asking the facial nerve, ma. Near the facial nerve, when you are
It is
going.
stellomastid foramen. It bleeds.
The retromandibular vein will be.
Vein.
Transverse cervix.
That will be always an identification point. And if they have a bleeding, you must be very careful because
Yes.
that you are very near that.
That you are nearing the facial nerve.
So you are identified, you have do trunk, and which one you have to preserve? Suppose you are given an option, you have no other go, you have to cut one portion. Which one you will preserve more?
Zygomatic.
Zygomatic.
No,
Why?
no.
No. There are 5 branches, no?
Yes, sir.
Okay, which is more important? For your life, which is more important, Amma? Seeing is important or eating is important?
Seeing is important or eating?
Of the 5 special senses, which is most important?
Seeing.
Eyes, right? So, which nerve?
Zygomatic is preserved, sir, so that there's proper closure of eyes and there's no corneal ulcerations.
You have a lot of options. But most important, you need to preserve the buccal. Okay. So, what you said, some say hemorrhage will be there, and from hemorrhage from where? In a parotid surgery, which will bleed?
Retromandibular vein.
How it is formed? What is retromandibular vein?
What are the tributaries of retromandibular vein? How it is formed?
It has 2 branches, anterior and tributaries to anterior and posterior. The anterior combines with the anterior facial vein and forms the common facial vein, whereas the posterior branch combines with the posterior auricular and forms the external tubercle.
Good. What is the plane of the, what is the sequence of the nerve, vein, artery, which is posterior, which is anterior?
The superficial most is nerve, followed by vein, and then arteries.
How you treat Frey syndrome? How you treat parotid fistula? Complications of parotid surgery.
So for Frays, you can prevent Frays by having to raise a thicker flap, or you can use the interposition of muscle. Medically, you can go ahead with antiperspirants.
How you identify the which region of the skin is affected by this Frey syndrome? How you identify that, and you have to give some injections over there? How you identify that the part of the skin, the sympathetic supply is overtaken?
Large iodine test can be done.
How you do that?
You apply iodine over the area of the parotid, like angle of mandible.
Okay. What will happen?
And then allow it to dry and apply starch.
Yeah.
Once there's sweating, it reacts to the starch and turns into a blue color.
There is change, color change, changes to
Blue
blue
color.
color. We have marked that region and what injections you will give. Before, after
Botox
that,
injections can be given.
Botox injections. After that, if it is not sufficient,
Have you seen Botox injection being given?
Not for this case.
not
Which
for this
needle you
case,
will
general.
use? Which needle you will use?
So can you repeat the question, sir?
Which needle you?
Needle size. And what is the amount? Which botulinum toxin you give?
A, sir.
Yeah, very good. Okay. You must use the 27 gauge needle. 0.2 to 0.4 ml.
What types of fistulas you have?
That parotid fistulas can arise from gland or it can arise from duct.
Have you managed from gland? Have you managed from duct?
So you can ablate the gland.
How do you manage from fistula from the gland? You ablate the gland?
How do you make out the fistula?
No, conservative management, amma. How you manage that?
So you can give hyoscine.
No,
to reduce
simple
the
compression. Only compression, external compression. How you treat the duct fistulas? Do
so
you name
can
any
do
surgeries?
Newman surgery.
Human.
It's a common indication, a common area where you get a duct fistula.
You have to look for either intraoral communication or extraoral communication. Okay. If there is intraoral communication, there is no need to do anything. Okay. If there is an extraoral communication only, you have to do so many surgeries and duct transplant also. Okay. And cannulation. These are all the procedures. Newman's, Cartman's, so many. You have to ablate the auriculotemporal nerve also. What is that procedure called? Ablation of auriculotemporal. You have to cut the auriculotemporal nerve. It is a secretogogue, no? Auriculotemporal parasympathetic is secretogogue for parotid. If you disconnect that auriculotemporal nerve, there won't be any secretions. Okay.
What is that innervation for the parotid? How the innervation comes from the parotid? From where you get the innervation or the
inferior salivary neck.
Inferior
very good.
place?
So aortic gland.
Jacob's nerve too.
Okay. Good.
Okay.
What is Jacobson's tympanic neuronectomy? In which condition you will do? What is that procedure actually? It's done for the Frey syndrome.
Tympanic neurectomy.
Jacobson's tympanic neurectomy done for the Frey syndrome. Where the surgery will be done and what will they do in that procedure?
Middle.
Is it middle ear? We have to do surgery over the middle ear. You have to cut the preganglion glossopharyngeal nerve. Already postganglion nerve cut, no? You have to cut the glossopharyngeal nerve in the middle ear. Okay? So what is rule of 20? What is rule of 80 in parotid? What is rule of 80?
And rule of 80.
Rule of 80.
The superficial salivary gland is having 80% function of the parotid, whereas the deep has 20%.
No function. What is
Start
function?
off with the most common ones, Dr. Sushma, please. Don't come up with the least common. What's the most common?
You have to know this. These rules are compulsory. 80, rule of 80, rule of 20.
80% are benign.
Very good. 80% are benign. Very good. Next.
What is that 80% benign?
80 benign, which is more common in benign.
80% are benign. In that 80%?
Pleomorphic adenoma.
Very good.
80% is pleomorphic adenoma.
And 80% are, they occur in which lobe?
Superficial.
How many surfaces are there in the parotid? How many borders are there in parotid? 80% is lower pole. 80% lower pole, 80% benign, 80% pseudo, and one more 80% is there. In parotid protocol, CT protocol of the parotid, if there is this 80% comes, what is that? CT protocol for parotid. Your CT protocol of pancreas is there now. Like that, you have CT protocol for the parotid also. Okay, if the tumors are anterior to the stylomastoid ligament, they are comes from the deep lobe. If the posterior, they are from the parapharyngeal space. This is 80%. What is 20% rule? Rule of 20.
20% malignant,
Very good.
out of which most
20%
common
they
is
involve.
mucoepiderm.
When they 80% involve superficial lobe, 20% is from deep lobe, no?
Deep lobe.
20 malignant, 20 deep lobe, again 20 is recurrence in superficial because of pseudopores. 20% recurrence. One more 20% is intragranular lymphatics, 20%. Parotid is drained intragranular lymph nodes in 20%, 80% to the paragranular lymph nodes. This is the rule of 20 and rule of 8. Sir, go ahead, sir.
Yeah. So what is accessory parotid gland? Accessory splenic cyst you heard, no? Similarly, accessory parotid gland.
What is it called? There's another name for it. Very, very typical name for it. Parotid Socia. Okay, so now you say, tell it the answer. Here, Dr. Shushma, go on. What was asked? What is accessory parotid? What's so important about it?
It's an extra.
It's not extra, man. It is the parotid within the capsule. Only you will see it is very close to that.
It is close to some
They
structure.
have a separate.
So because
So
it's
within
time.
within the capsule, but they have a separate duct that drains.
Need not be, but okay. But you must read that. I mean, it has a lot of variation.
It is close to the duct, so it can damage the duct while removing it. Okay.
So suppose you think on the table you are seeing the facial nerve is there is a lot of tumors are around this. You are not able to remove it fully. All the tumors you are not able to remove. What will you do?
So post-operatively, we can go ahead with radio.
So you will not cut.
Can you sacrifice the facial?
Do a radical.
No. You should not cut. You should not. You have to preserve facial nerve, no? What you said is correct. I have to give.
What you are for recurrent nerve and facial nerve, you should not go for cutting. You must be. What is comprehensive parotidectomy?
When you remove the infiltrating stuff.
All that what you said can be put in there. Extracapsular, superficial parotidectomy. So when you want to say that, can be also put whatever as per the need. Do you have a superficial parotidectomy preserving the nerve? There is no term called that. When you have total parotidectomy only, you should say will we preserve the nerve or not. When you say superficial parotidectomy, you should not use the word nerve. So what you will do if it's a deep lobe is involved?
You can remove the deep lobe in piecemeal fashion.
Remove that, right?
So you can do a total conservative where you remove the superficial and also a deep lobe in piecemeal fashion.
What is the advantage of MRI over CT in parotid? Near Bailey has given about MRI.
Let me ask you.
Infiltration.
What are the indications? What are indications for MRI and what are the indications for CT in this?
CT, yeah.
So you can identify the facial nerve infiltration, the soft tissue infiltration for a parotid.
No infiltration, Amma. Infiltration is different from.
You are talking about perineural invasion.
Perineural invasion, perineural spread. Perineural spread. What is the difference between perineural spread and invasion? Is it same or different?
It is different.
How it is different?
So it affects the function
Which
of
is vertical growth, which is horizontal growth. Horizontal spread, which is vertical spread, which is horizontal spread.
Perineural is horizontal.
Horizontal. Is seen in MRI. Okay.
Nice.
Invasion is seen in biopsy. Okay. That is the difference. It's the investigation. It is biopsy, histopathology. Okay. And what are the indications for CT?
See for the bony, like
skull-based involvement. For skull-based involvement, for malignancy, Neuer-Bailey has given that MR is better than the CT, but for bony involvement, CT is the investigation of choice. Okay, sir. It's for me.
Any other indications for CT? One is bone, you said fine. Any other indications? Recurrent parotid tumors, right? Lymph node involvement and deep lobe involvement.
For deep lobe.
Okay. So these are the indications. Facial nerve involvement can also be seen by CT, but it's better appreciated. Neurovascular invasion is better seen in MRI.
What is the surgical importance of stylomastoid ligament, which is the part of deep lamina of the cervical fascia? It is a thickened part of
the dissection.
Huh?
So it's a posterior extent of dissection that you.
What is the surgical importance of the stylomastoid ligament? It is a thickened part of the deep lamina. Okay. What is the importance? It separates two glands. Which glands it separates?
Submandibular and.
Very good. Very good.
Okay.
Can we conclude, sir?
Yes, sir.
Yeah. Do we conclude? Okay.
Yeah, we can.
Yeah.
Okay, Dr. Sushma, anything you would like to ask? Any confusion? Any queries? Any doubts?
Thank you for the session, sir. Okay. It was very useful and educative.
Good. Well presented. Right.
Thank you.
Okay. Good night, sirs. Thank you so much
for being here. If there is in the exam, if there is a solely, definitely the parotid or submandibular gland, they will be kept for the examination.
You will get it.
There is not much to examine, but only the way how you are going to palpate the deep lobe when you are saying that, and how you are going to palpate the duct, and what you are going to see the ductal opening. So all these are important, and you are feeling, and the boundaries of the parotid region. You should not make any confusion on that, and you must be thoroughly read. Innervations, and you must know, and identification of the facial nerve, and how you are going to identify, and how you are going to identify the even greater auricular nerve, and from where it are coming. All that theoretical part, but that will be only asked in the examination. Much more importantly, in a parotid, because we don't have much other things on our examination. Not much we are going to do that. Okay, but you have done well. Keep it up.
Good night, sir. Thank you so much.
I want to convey my thanks to Kanagabelu sir for inviting me this August platform.
So please join in again.
Yeah,
please find time to come, sir.
Definitely,
happy to have you.
Definitely. Actually, last class was my PG she has to be present, but some reasons postponed. Next time I will try to accommodate my PG to present this case. Thank you.
Okay, sir.
Good night.
Good night.
Good night, everyone.
Good night.
Good night, sir.